Hi, I'm Barbara Lewis, and welcome to Riley Today. This video journal is designed to provide busy physicians with up-to-date information relevant to the medical care of children. Riley Today is produced by the Indiana University School of Medicine and presented by Riley Hospital for Children together with Clarion Health Partners. This program and its accompanying web-based supplement also offer a convenient way to earn continuing medical education credits, which we'll discuss later. It's important to us that we continue to keep our focus on you, the physicians in the community, by providing not only pertinent medical information, but also by ensuring that we keep you abreast of the latest services, resources, and developments that Riley Hospital is offering you, your patients, and their families. Dan Fink, Chief Operating Officer of Riley Hospital for Children, shares some of the exciting new services and developments taking place at Riley.
Hello, I'm Dan Fink, Chief Operating Officer of Riley Hospital for Children. We're pleased to bring you another edition of Riley Today. We hope that you continue to find these useful, educational, and meaningful to your work treating patients and families. I wanted to share with you some of the improvements occurring at Riley, designed to better serve you. In March, we sent the first issue of the Riley Physician Update, a newsletter we're sending to physicians across the state of Indiana with information about new developments, new physicians, new services, and new treatments at Riley that is relevant to the service you provide to your patients and community. We continue to grow our Physician Liaison program. These Riley representatives visit you and your office to find ways to enhance the service we provide to you and to address any questions or concerns regarding Riley or Clarion you may have. We are also pleased to announce that patient wait times for many of our subspecialty clinics and hospital outpatient departments have significantly decreased over the last several months.
That's the way. You got one really good.
We are working with all services across the hospital to get your patients in more quickly, reduce waiting times, and to effectively communicate with you about the care your patients receive at Riley, including sending admission notices, providing communication during hospital stays, and then sending prompt discharge notices. We are continuing to address service issues you helped us identify and hope you are seeing the results. We also wanted to make sure you are aware that Riley Hospital at Clarion North Medical Center is open and available to take patients in their neonatal intensive care unit, their pediatric intensive care unit, and their general pediatric inpatient floor. All three units are staffed 24 hours a day, 7 days a week by Riley physicians specially trained in pediatric intensive or hospital care. Located in Hamilton County, north of Indianapolis, at 116th and Meridian Streets, Clarion North Medical Center is a full-service hospital equipped with an ER to treat children and their families. Clarion North also provides unmatched women's services, including a wonderful birthing facility. Though Riley offers many pediatric subspecialty clinics and hospital services at Clarion North, we're concentrating on providing the more simple and routine care there, with easy referral to the Riley downtown campus for tertiary or quaternary care. You can learn more about Riley Hospital of Clarion North by visiting www.clarionnorth.com. All of us at Riley will continue working to identify better ways to enhance service and communication so that we can better partner with you to provide the highest quality care for the children of Indiana. We will continue to communicate with you about key developments at Riley Hospital for Children through one-on-one communication, our physician newsletter, and our Physician Liaison program. Thank you, and please do not hesitate to email suggestions or questions to rileyfeedback@clarion.org.
Feedback from physicians across the state has led to our selection of many topics over the years. This issue's focus concerns neonatal bowel obstruction, chest lesions, And our first segment, minimally invasive surgery. In the 1980s, laparoscopic techniques first became popular in the efficient removal of the gallbladder. Over time, these techniques and the tools used to perform them have been further developed and fine-tuned and are now used in the repair of many conditions. In fact, today's minimally invasive surgical techniques are preferred even for pediatric patients. Studies have shown that patients undergoing laparoscopic surgery generally have smaller incisions that can often be hidden in skin folds, heal quicker, and leave the hospital sooner than with traditional open procedures, and use less narcotics, which is believed to be reflective of less pain. Many conditions can be repaired or at least evaluated using laparoscopic techniques. In this segment, Dr. Fred Rescorla, Director of the Section of Pediatric Surgery and Surgeon-in-Chief at Riley Hospital, will discuss how such techniques are used to evaluate and repair many thoracic and abdominal conditions found in children. At the conclusion of this segment, we should be able to list the benefits of minimally invasive surgical techniques, describe the correction of common chest problems using minimally invasive surgical techniques, and describe the correction of common abdominal problems with minimally invasive surgical techniques.
Laparoscopic techniques came into use in the late 1980s, initially primarily to remove the gallbladder. With time, as surgeons became more comfortable with these techniques, many other procedures followed, building on these methods of laparoscopic surgery. Today, when surgery is performed on children, we prefer to use the minimally invasive techniques. The advantages of these are shorter length of stay, less narcotic use, reflective of less pain, and smaller incisions, often hidden in skin folds. Two of the most common thoracic conditions that we perform surgery on in children are pectus excavatum and pectus carinatum. A pectus excavatum is much more common, and this refers to the depression defect of the chest wall, the sunken chest where the sternum and costal cartilages are sunken in. It occurs in about 8 in 1,000 live births. This occurs primarily in boys. It can be associated with Marfan syndrome, but most children have no associated syndrome with this. The presenting symptoms can include chest pain, shortness of breath, inability to keep up with peers in physical activity, which may be reflective of decreased cardiac and respiratory function and exercise reserve, basically. There can also be some children who are bothered by the appearance of the defect, and this can lead to indications for surgery. When we see these children, we usually do a complete physical history and physical exam and try to evaluate whether the defect is symmetric or asymmetric, that being one side of the costal cartilage more depressed than the other, leading to sternal rotation, which affects how we repair the defect. We generally obtain either a 2-view chest x-ray to estimate the depth of the defect, or more commonly obtain a limited CT scan. And we're trying to determine the ratio of the transverse distance within the chest to the distance from the back of the sternum to the anterior portion of the vertebral body, and that is the CT index. In general, a number greater than 3.2 is considered to be significant. A symptomatic defect with a number of the index greater than 3.2 would be an indication to proceed with surgery. We generally prefer to hold off in repairing these until the children are more in the 10 to 12 year range or somewhat older. The repair of these has undergone significant evolution over the past 15 to 20 years. Basically, 2 techniques have been in place for repair of these. The more traditional open ravage technique involves resecting the cartilage, putting a fracture in the sternum, bringing the chest wall up to its normal position, and placing a very small supportive bar, which is in for about 6 months. In the late 1990s, Dr. Donald Nuss proposed a somewhat different technique to elevate the sternum. The more commonly used, newer technique is a minimally invasive technique in which we approach the chest from mid-axillary incisions. We come across the sternum and acutely elevate the entire anterior chest wall. We place a very large bar in place which holds the anterior chest wall in an elevated position. The bar rests on the chest wall laterally and is secured to the chest wall. This bar remains in place for approximately 2 years to allow chest remodeling to occur, and then is removed. In both procedures, the children are hospitalized for approximately 5 to 7 days. They have an epidural catheter in place for pain control. In terms of physical activity after the pectus excavatum repair, with the newer minimally invasive technique, we limit them for approximately 6 weeks and then let them go back to full activity. With the older Ravitch technique, we generally keep them out of contact sports for at least 6 months until the chest is fully healed. After surgery for pectus excavatum, we generally see these children approximately 1 month after surgery and then every 6 months thereafter until the bar is removed. If any abnormalities of the chest or different changes in appearance would be noted before that time, we would like to see them. Then the bar removal is generally an outpatient procedure. In terms of the two techniques, we prefer the newer minimally invasive procedure for the main reason that it does not involve any cartilage resection or sternal fracture. It leaves the chest wall just with acute elevation, but without not any reconstruction or long-term effects. We find that the chest can grow through puberty and the rest of adolescence in these children, so we really prefer the less invasive technique. There's no large incision across the anterior chest, and most children prefer having just the mid-axillary incisions. The pectus carinatum, the protrusion defect, is somewhat less common, often presented in adolescent boys, sometimes in girls, and is often asymptomatic but can be associated with chest pain. There are usually not physiologic defects associated with this in children. We generally opt for repair in these children when they are symptomatic with pain or some type of discomfort related to their chest wall. The options for correction of this include a compressive device in which an orthotic device is made which applies constant pressure to the defect anteriorly. The advantage to this is that it avoids surgery. The disadvantage is the child has to wear this compressive device 24 hours a day for the first 6 months or so, and then 18 hours a day thereafter for until the defect corrects. Surgical excision involves resecting the protruding cartilage, placing a small fracture in the sternum to bring it down to a more normal location. This is generally a much less invasive procedure than the pectus excavatum repair, much shorter hospital day, perhaps 1 to 3 days. After surgery for pectus carinatum, we would generally see the child back in 3 to 4 weeks, and then perhaps 2 or 3 months later. Should any abnormality occur during that interval between when we see them or thereafter, we would like to hear from them at that time. In children who have the orthotic compressive device, we generally see them 3 months after it's initially placed, and then approximately every 6 months thereafter to make sure that the brace fits appropriately. And many of these children do develop some redness of their skin as a pressure point. However, when the brace is discontinued, it generally resolves. Should any untoward effects occur or be noted, we would like to hear from their primary care physician at that time. In children with the orthotic compressive device, we do not place any restrictions on them in terms of physical activity. In terms of referral timing for pectus excavatum and carinatum, we generally do not perform the surgery until they're perhaps in the 9 to 11 year range, but we're happy to see them anytime earlier if the families would like to discuss operative repair. The other advantage early referral offers us sometimes is that we are able to obtain a documentation of the severity of the defect and then follow this with time. Sometimes it's important to document an increased depth of the defect, particularly in pectus excavatum, and sometimes in terms of determining the progression of the defect, that's an important factor. Minimally invasive surgery for the chest also involves thoracoscopy, and we do many procedures on children when we're dealing with either post-infectious empyemas, in which we go in with a scope and remove all the purulent material and decorticate the lung. We also use this technique for biopsying of mediastinal or pulmonary nodules, and often resection of various mediastinal tumors such as esophageal duplication cysts, small neuroendocrine tumors, or other masses within the thoracic cavity. The advantages of these techniques are primarily to avoid a thoracotomy. Thoracotomy is one of the most painful surgeries that we perform on children, and in many of these we can simply go through between the ribs, much like putting in a chest tube, and accomplish the same procedure. Some children will develop post-pneumonic fluid collections, and should the child remain febrile during this time, it may be reasonable to consider the child for thoracoscopy. In general, if there's lung collapse or a large effusion in a child who is not responding to medical management with antibiotics, we would consider thoracoscopy with removal of the fluid, decortication of the lung to allow full pulmonary expansion and a faster recovery. Children with empyemas or post-pneumonic fluid collections could either be sent to the pediatric surgical division or the pediatric pulmonary division and managed from that point on. In the abdomen, there are many minimally invasive or laparoscopic procedures which we very commonly perform. One, laparoscopic cholecystectomy, although not terribly common in children, is still fairly commonly performed at Riley Hospital. This can be performed for stone disease. Some children with hemolytic conditions have stone formation and require cholecystectomy. If the child is symptomatic with gallstones, we generally would recommend a laparoscopic cholecystectomy. And we really believe that nearly every child who needs a gallbladder removed can have it done with a scope technique. Even if stones pass into the common bile duct, this can often be managed in a minimally invasive technique. Biliary dyskinesia is another condition which benefits from laparoscopic cholecystectomy. Although this is related to gallbladder disease, these children are often picked up in children with chronic abdominal pain. The diagnostic modality of choice is the Decida scan, and a Decida scan with an ejection fraction of less than 35% is considered to be abnormal. In addition, when cholecystokinin is given during the test, the children often have pain. This can be a rather difficult group of patients to treat. However, we know from a series which we performed at Riley with 70 of these children that pain relief can be achieved in approximately 85% with a laparoscopic cholecystectomy, thus avoiding more expensive and somewhat hazardous diagnostic tests such as ERCP. Another procedure which we commonly perform in children is laparoscopic splenectomy. The indications for this can include hereditary spherocytosis, idiopathic thrombocytopenic purpura, sickle cell anemia with splenic sequestration, and a few other conditions. This is one procedure in which the laparoscopic technique has been proven to be much better than the open technique, in that the children use less narcotic, have shorter lengths of hospital stay, and have a much better cosmetic appearance. In addition, over the past several years, we've gone to even smaller and smaller instruments, down to 3 millimeter instruments for many of the openings. The spleen is totally detached from the body in the intracorporeal position and then placed in a bag, which is brought out the umbilicus, and the spleen is then removed in very small fragments. These children do very well, and the average length of stay is approximately 1.2 days. Another procedure, that for gastroesophageal reflux, is the Nissen fundoplication. This is being performed more and more commonly with the laparoscopic technique. The indications for this are generally uncontrollable gastroesophageal reflux or some other complications such as erosions, Barrett's esophagus, or stricture of the esophagus. This technique also has the advantage of less pain, shorter length of stay, and a much better cosmetic appearance. The results between laparoscopic and open techniques are equivalent. The children generally can start feeding 1 day after surgery and often have between a 24 and a 48-hour stay. This procedure is performed more commonly in neurologically impaired children. The management of appendicitis has also been affected by the laparoscopic technique. Most children with appendicitis that we manage at Riley have their appendix removed with a laparoscopic appendectomy. We find this is very advantageous in all stages of appendicitis. In some children with a localized abscess, we will opt not to do an initial appendectomy, but will drain the abscess with our interventional radiology colleagues and do an interval appendectomy 6 or 8 weeks later. With the children with acute appendicitis or necrotic appendicitis, the laparoscopic approach is a 3-trocar technique, the largest in the umbilicus, and this is where the appendix is actually removed, and then 2 smaller incisions. We find that we're able to manage appendicitis in all the various stages with the laparoscopic technique. Although the studies have been somewhat difficult to determine a true advantage to the laparoscopic technique, without question, the incisions are smaller and the amount of postoperative narcotics is less. The length of stay, however, is not affected by the laparoscopic technique, since the length of stay is more dependent upon the process of appendicitis, in that a child with a perforated appendicitis will need to remain in the hospital until they have a normal white blood cell count, are eating well, and are afebrile. When these criteria are met from either an open or a laparoscopic appendectomy, the child is released. Should the child at home develop a fever, especially in the first week after appendectomy, we would be very concerned about the possibility of a postoperative abscess. We would generally check their white blood cell count, and if it is elevated or if the child has persistent fever, we would most likely consider an abdominal CT scan to evaluate for the potential of postoperative abscess in these children. A laparoscopic appendectomy, we think, is without question advantageous for children with appendicitis. Other conditions in children which can be managed laparoscopically included diseases of the ovary, such as ovarian cysts, some ovarian tumors, ovarian torsion. These can all be managed and at least investigated with a laparoscope. Sometimes an open procedure will be required, especially if the child has an ovarian tumor. Ovarian cysts can be therapeutically aspirated or unroofed. Torsion can be managed. In children with torsion, even if the ovary appears to be necrotic, we will usually leave it in place, as many of these children are found to have persistent ovarian tissue on follow-up ultrasounds. We'll often perform an oophoropexy of the opposite side in the children with torsion. Laparoscopy is also useful in children with tumors. Sometimes we'll obtain a biopsy if the child is not going to undergo initial resection, and other areas of the abdomen can be thoroughly investigated for the presence of tumor. Sometimes liver biopsies for children with tumors within the liver are performed under laparoscopic guidance to avoid a laparotomy and not have to delay chemotherapy. Laparoscopy is also very useful for very common conditions such as management of inguinal hernias, hydrocele, and undescended testis. Hernias are perhaps one of the most common conditions that we manage in pediatric surgery. Most children show up with a unilateral inguinal hernia. Children with hernias should be referred at diagnosis. We would generally recommend repair of a hernia at the time of diagnosis. The chance of a hernia resolving is very, very low, and the risk of incarceration and strangulation of bowel or damage to the testis is very significant. In many of these children, we will offer the family the option of performing laparoscopy through the involved hernia sac and looking to see if there's a patent processus vaginalis on the other side. This is obviously much more common in young children, and we'll generally recommend this up to approximately 2 years of age and perhaps even older in girls with hernias. If a patent processus vaginalis is identified on the opposite side, we would recommend repair of that hernia at that time. In children with hydroceles, we generally observe hydroceles until approximately 12 months of age, as many will resolve spontaneously. If they persist at that point, or if they have a very large communicating component, we may consider surgery at that time. Children with undescended testis probably should be referred at about the time of diagnosis. If the testis is in the inguinal canal or slightly below that, it can probably be observed until approximately 6 to 8 months of life, and if it does not descend all the way by that point, should be considered for operative repair maybe at 10 to 12 months of age. In children in which the testicle is not palpable in the inguinal region or in the scrotum, early referral is indicated, as those are less likely to descend spontaneously. We generally approach the child with the undescended testis with a thorough physical exam. If the testis is non-palpable, we will often do a laparoscopic evaluation to determine the presence or absence of an intra-abdominal testis. If an intra-abdominal testis is identified, it is often managed with the definitive or initial step with a laparoscopic technique. In general, after laparoscopic surgery, little follow-up is needed. The most troublesome wound is actually the one in the umbilicus, and sometimes these drain, sometimes a little granulation tissue develops, and if this occurs, we generally treat this with silver nitrate. But for the most part, most of the children have no further problem after this procedure. Minimal access procedures have also affected the way we manage children with Hirschsprung's disease. In the past, most children with Hirschsprung's were managed with a colostomy followed by a pull-through procedure. Since Hirschsprung's in approximately 80% of children only affects the rectosigmoid colon, we can now perform this procedure in a primary perineal technique. In this technique, we go in a transanal fashion and remove the inner lining, the mucosal and submucosal tissue of the rectum. When we get above the peritoneal reflection, we then remove the entire rectum and sigmoid colon. We remove it until we get into the normal bowel, that being that above the Hirschsprung's affected bowel. We then suture the normal bowel just above the dentate line, resecting the involved Hirschsprung's disease. This is an intra-abdominal procedure which is performed in a transanal fashion. These children avoid an abdominal incision, and this has markedly revolutionized the way we treat children with Hirschsprung's disease. The length of stay is often in the 2 to 4 day range. These children tend to do very well. Some require occasional anal dilatation after the procedure, but for the most part, do very well. Minimal access surgery is preferable to the open technique whenever possible in children. The primary advantages are less pain, reflected by less narcotic use, shorter length of stay, and smaller incisions. We try to adopt these techniques to nearly every procedure which we perform in children. As surgeons become more and more comfortable doing more techniques laparoscopically, they are pushing it into even more techniques that have been traditionally performed in an open fashion. We perform many bowel resections with a laparoscopic assisted technique. Hilar myotomies, which are rather rare in children, are performed laparoscopically. And I think in the future we will continue to adopt more and more procedures that are currently being performed in an open technique to the laparoscopic approach.
It seems that more and more surgeries are being done using minimally invasive techniques, and the future of this field holds even greater promise. Riley Hospital's pediatric surgical team offers not only experience with these techniques, but also experience with performing them in children. Seasoned neonatal surgical specialists, radiologists, anesthesiologists, nurses, and pharmacologists bring a wealth of knowledge and expertise to their young patients and are a resource for you and your patients throughout the state. Neonatal bowel obstruction is another condition in which the pediatric expertise of the entire care team plays a critical role. Physicians in communities across the state are likely to see only 8 to 15 cases of neonatal bowel obstruction a year. The incidence is about 1 in 5,000 live births for the more common types of obstructions seen at Riley Hospital. However, when it does occur, neonatal bowel obstruction is a potentially life-threatening condition. Being able to distinguish it from other, less critical problems with similar symptoms is tricky and vital. Early diagnosis by community physicians and early transport to a neonatal surgical center are essential to positive outcomes for these young patients. Dr. Thomas Rouse, Clinical Assistant Professor of Surgery at Riley Hospital, will lead us through the diagnosis and care of neonatal bowel obstruction. At the conclusion of this segment, we should be able to list the primary clinical signs and symptoms of intestinal obstruction in a newborn, describe the significance of bilious emesis in infants, and differentiate between the signs of upper and lower intestinal obstructions.
Some newborn obstructions are actually diagnosed in the fetus. Typically, these will be the higher intestinal obstructions, such as duodenal atresia or a proximal jejunal atresia. The effect of this is polyhydramnios in the mother, and in duodenal atresias, this occurs in upwards of about 70% of mothers. The diagnosis would be made by the obstetrician, and if appropriate, a referral to a high-risk maternal fetal medicine physician. At this stage, a confirmatory ultrasound would be done, as well as screening for other congenital anomalies. And this can include cardiac anomalies, as well as chromosomal anomalies if the parents would desire. As part of our care for the family, we would very much like to meet with the parents of a fetus who is suspected of having an intestinal obstruction. At that meeting, we would outline for the parents the early post-delivery care for their infant, the surgical management, and then the post-operative recovery. Importantly, we'd also discuss the short and long-term problems which may or may not be seen with any particular type of obstruction. Most often, however, the diagnosis is not known prenatally, and therefore the signs present in the infant after birth. This may be within the first hours of life or within the first couple days of life. Most complete obstructions will present within the first 48 hours after birth. The signs really are fairly simple. They are poor feeding, irritability, abdominal distension, vomiting, and very specifically bilious vomiting, which more often than not is a sign of a mechanical obstruction. Similarly, failure to pass stool within the first 48 hours is highly suspicious for a low intestinal obstruction. Infants with higher intestinal obstructions may pass a stool, and this should not be looked upon as a sign that an obstruction cannot be present. Of all these signs and symptoms, the hallmark of a potentially life-threatening intestinal problem in the newborn is bilious vomiting. That implies that there's a obstruction beyond the ampulla levator, which is the point in the intestinal tract where bile drains into the duodenum. This should be a red flag for any physician caring for an infant that a potentially life-threatening intestinal problem is present. Not all infants with these signs or symptoms will have an intestinal obstruction. However, one must assume that an obstruction is possible given these factors. Non-obstructive problems that can cause the same symptoms would include electrolyte abnormalities, sepsis, or a more rare cause of hypothyroidism. Screening x-rays may be helpful in determining a higher or lower likelihood of a bowel obstruction, and these would be a plain radiograph of the abdomen as well as a chest x-ray. As I think about intestinal obstructions in the newborn, I divide them into upper and lower intestinal problems. The diagnostic approach typically is different between the two, and the frequency of other anomalies also differs. For upper intestinal obstructions, the symptoms are more vomiting and bilious vomiting. There's typically less abdominal distension than in the more distal obstructions. With duodenal atresia, the obstruction may be identified even before the first feeding. Babies who vomit bile with birth or shortly after birth, or if after placement of an orogastric tube, 25 to 30 cc's of bilious fluid is found to be in the child's stomach, this should be suggestive of an intestinal obstruction. From this point, plain x-rays can be performed even before the child is fed the first time. With duodenal atresia, there's a much higher incidence of other anomalies than with many of the other types of intestinal obstructions. Specifically, this can include cardiac anomalies as well as chromosomal abnormalities. About a third of infants with duodenal atresia, in fact, will have trisomy 21, and evaluation, therefore, by our pediatric cardiologists and medical geneticists is almost always performed. The urgency in a child with duodenal atresia is to decompress the stomach, obtain intravenous access for fluid hydration, and look for other anomalies. Not infrequently, the repair of the duodenal atresia will be delayed so that other anomalies can be stabilized or corrected prior to repair of the duodenal obstruction. Usually we can secure the diagnosis of duodenal atresia without any contrast studies. The classic radiograph of the double bubble sign seen on a plain abdominal x-ray secures the diagnosis. It's important that only 2 pockets of air are seen on the x-ray and that there's no air beyond the duodenum. Even a very small amount of air would indicate that this is not duodenal atresia and make us very concerned about malrotation of the intestine. Maternal polyhydramniosis is another indication to seek out the diagnosis of duodenal obstruction very early. Infants with duodenal atresia often have the findings in utero of maternal polyhydramnios, and this occurs in excess of 70% of those babies with duodenal atresia. The 2 other proximal intestinal obstructions that we can see in newborns are that of a proximal jejunal atresia or malrotation of the intestine, oftentimes with intestinal volvulus. The signs and symptoms could be the same for both. They would be little to no abdominal distension, early vomiting, and bilious vomiting. And there may be an irritability with the malrotation that would not necessarily be seen with the small bowel atresia. Plain x-rays of the abdomen may look very similar. It will show air beyond the duodenum. It may show a lot of air or very little air. The important point is that it's difficult to decide based on plain films whether there's malrotation or whether there's a small bowel atresia. In these instances, oftentimes contrast studies in the form of an upper GI are obtained to determine the diagnosis and the urgency for surgical treatment. With malrotation of the intestine and volvulus, there's an acute urgency in making a diagnosis and relieving the obstruction. The bowel can go from normally perfused to necrotic within as short a time as 4 to 6 hours. So urgency in making the diagnosis is the key factor in prompt, proper, and life-saving treatment for these little babies. The more distal intestinal obstructions more often will present slightly later than the proximal obstructions. Having said this, children can become symptomatic within the first 12 to 24 hours of life. Typical findings would be abdominal distension, poor feeding, vomiting, which may not be bilious at the start, but will progress to bilious vomiting over time. Also, failure to pass stool within 24 and certainly 48 hours is highly suggestive and strongly suspicious of a distal intestinal obstruction. These can really be grouped into several types of obstruction, from distal atresias of the small intestine to the meconium obstructions. Meconium ileus is an obstruction in the distal small intestine. It is almost always associated with cystic fibrosis. But upwards of about 15 to 20% of infants with cystic fibrosis can present with meconium ileus. The colonic problems also can be classified as meconium plugging of the colon, or more commonly, Hirschsprung's disease. Hirschsprung's disease is sometimes termed a functional obstruction because there's no mechanical barrier to the passage of stool. However, there is a lack of ganglion cells or nerve cells in the wall of the intestine, which prohibits normal peristalsis, and therefore the point where there are no ganglion cells becomes a point of functional obstruction. Most often, children with Hirschsprung's disease present as the first in their family, but there are those rare families in which this can occur in multiple family members. So this would be another problem where a quick query of whether there's been an intestinal obstruction in a baby can help lead us to an earlier diagnosis. Finally, the most distal obstruction is that of imperforate anus. Usually this is quite obvious on physical examination, but occasionally a small amount of meconium can come through a fistula from the lowest rectum to the perineal skin and give the appearance of a normal anus. So a child you suspect having an intestinal obstruction should have a thorough evaluation of the perineum to make sure there's a normal anal opening. Plain x-rays of the abdomen in distal obstructions will look the same for many of these types of problems. That is, they will show dilated bowel diffusely. They may show a dominant loop of bowel in atresias as opposed to a more diffuse, similarly dilated loops of bowel in Hirschsprung's disease or meconium plug syndrome of the colon. Curiously, in meconium ileus, there may be very few to no air fluid levels, which is uncommon for an intestinal obstruction. This probably relates to the thickness or tenacity of the meconium, which is seen in these infants with cystic fibrosis. The various types of obstruction can oftentimes be delineated and we can come to a fairly secure diagnosis based on a water-soluble contrast enema. This often, but not always, will show a transition area typical of Hirschsprung's disease or large meconium plugs in the colon. We'll also definitely identify the more rare colonic atresia. Similarly, children with meconium ileus may not only have a definitive diagnosis based on the contrast enema, but in about half of the cases, the obstruction from the thick meconium can be relieved as a result of the contrast enema. In Hirschsprung's disease, the definitive diagnosis would be made with a suction rectal biopsy, a procedure very easily performed at the infant's bedside. Similarly, children with meconium plug syndrome of the colon have about a 5 to 10% chance of having Hirschsprung's disease. And these children likewise will often have a rectal suction biopsy performed prior to discharge. Very briefly, the repair of the duodenal obstruction most often is simply bypassing the obstruction. We don't remove the point of the obstruction, we simply suture the bowel around it. Small bowel atresias there's a variety of types, some of which have a normal intestinal length, and the obstructive area can either be bypassed or removed. There's an unfortunate few children who have a type of small bowel atresia in which a significant to large amount of their intestine is not present. These children are at risk for short bowel syndrome due to needing long-term total parenteral nutrition to sustain them. This can be a very difficult problem. Meconium ileus, we mentioned that half the children may be treated with the contrast enema. Obviously that means the other half need surgical correction. Sometimes children with this problem will have an associated intestinal atresia. Hirschsprung's disease has undergone a change in surgical philosophy over the last 15 years. Previously, children had always had an ostomy with Hirschsprung's disease. More recently, particularly in those children with in which Hirschsprung's disease affects only the rectum and lower sigmoid colon, enemas can be very effective at having the child stool. After about 2 to 3 months of having this done at home, the child can be brought back to the hospital for a single definitive surgical treatment for this problem. If you're evaluating an infant in your nursery who may have an intestinal obstruction but just aren't sure of it, the pediatric surgeons at Riley Hospital are always readily available to discuss the child with you. There's always a pediatric surgeon in-house on call 24 hours every day. If after our telephone conversation we both feel that transport is indicated because there's a possibility of intestinal obstruction, there will be a few basic steps that we'd ask you to take. These include making the child NPO, placing an IV for fluid hydration, and placement of an orogastric tube. Some infants with marked abdominal distension may have difficulty breathing, and an assessment should be made for whether intubation and mechanical ventilation should be performed prior to transport. We would also talk about what would be the best way to transport the infant. This may be by a local transport, or you as the child's physician may feel that the Riley Critical Care Transport Team is the best for your patient. The transport team provides physician, transport nurse, respiratory therapist, as would be indicated by the condition of the child. Upon arrival, your patient would be evaluated by the attending pediatric surgeon. Our primary goal is to determine whether there's a mechanical obstruction, which will need urgent surgical therapy. To help us make this determination, plain x-rays of the abdomen likely will be repeated, and often contrast studies, either a barium enema or an upper GI, x-ray will be performed. As in many cases, there's not just one congenital anomaly, and if needed, evaluation by other pediatric surgical specialists or medical specialists can be obtained at any time.
With Dr. Rouse and his team at the helm, you can rest assured that your young patients suffering from a bowel obstruction are in good hands. As Dr. Rouse mentioned, there is always a pediatric surgeon on site at Riley Hospital 24 hours a day, 7 days a week, who can take your calls. Should you become concerned about one of your patients, just call IMAX at 800-622-4989. Together, decisions can be made regarding the child's care, referral, and possible transport to a neonatal surgical center. Transportation from your hospital can be arranged locally or through Riley Hospital by calling 1-800-982-STAT. Infants and adolescents with chest lesions are also in good hands when referred to Riley Hospital, where they are likely to be seen by Karen West, professor of surgery. Dr. West often meets with parents who are terrified when they discover a breast mass in their child. It seems as if everyone has had an Aunt So-and-so who had a terrible outcome with breast cancer, and frequently Dr. West's first efforts are to calm parents who fear their child's breast lesion is a death sentence. In reality, while breast masses in any age group are concerning and should be evaluated, the majority of the breast lesions seen at Riley are benign. In fact, most go away on their own, but a few will need surgical intervention requiring the expertise of Riley's pediatric team. At the conclusion of this discussion, the viewer should be able to describe common chest lesions in infants and how to treat them, explain the causes, treatments, psychosocial concerns, and insurance issues related to gynecomastia in male adolescents, and describe common findings and treatment options related to breast masses in adolescent girls.
In infant conditions that we would see, most common initially would be that of breast bud formation just from the estrogen stimulation from mother. And that effect can last for several weeks, up to 3 months. There may be a little bit of fluid that might be secreted from the nipple or the areolar complex, and that's worrisome to families, but again, it's encouraging people just to give it time. It's something that will resolve. Doesn't need to have any surgical issues dealt with. Particularly, you don't want to excise any breast buds on a little girl. Keeping in mind that there are several medications that we use that can cause premature breast bud development or growth. Some of the common ones are cimetidine, which used to be used very commonly for treatment of gastroesophageal reflux, as well as the estrogen-bearing creams that were used for labial adhesions or the vaginal synechia, so that if we see that the estrogens are being absorbed transcutaneously, breast buds are beginning to grow in size, then certainly that's an indication for stopping those medications. Almost always are these breast buds in the infant age group are benign. They merely need to be watched, certainly no biopsies done. If there is a question of the size growing out of proportion to how the baby is growing in size, then certainly an ultrasound can be helpful because it can define the perimeters of the lesion, what it looks like, whether there's any fluid or not. Locally, a lot of the breast centers now are starting to build some expertise in taking care of younger children and doing breast ultrasounds. Certainly, if their individuals have developed an expertise and feel comfortable with the children, getting an ultrasound locally is very helpful just to be able to reassure the parents that it is not a problem. However, sometimes can be a bloody nipple discharge in an infant or a toddler. In this case, the most common thing we would worry about would be ductal ectasia, where you have a superinfection, usually with Staph aureus, and that causes the bloody discharge. These can simply be treated with antibiotic therapy. Usually you can feel a mass that's separate in one quadrant of the breast or another, and over a 10-day period of time, almost always does the bloody discharge abate, the mass disappears, and there's nothing else that you need to do. Usually this blood discharge is unilateral, and certainly that whenever a physician finds this, entity of the bloody discharge. Even though the children don't have a fever, you need to worry about a Staph aureus infection. They can always call us. We would advise doing a culture, putting them on an anti-staph agent, and we would be glad to see the child anytime, but a lot of times we never need to see the child. It resolves a one-time single entity without any further problems. Another common entity that we're seeing more of now are breast abscesses in the infant age group, oftentimes growing Staph aureus. We're seeing the community-acquired methicillin-resistant Staph aureus in more frequent entities. If we see a painful reddened mass that's tender to the baby, then we'll try oral antibiotics for 24 hours. If that's not successful, certainly intravenous antibiotics will be required. Probably 50% of those abscesses will resolve with oral antibiotic therapy. The rest will need to have surgical excision with dressing changes, and again, hoping not to distort the eventual breast development of a young girl. Another common lesion we'll find in infants, as well as some of the older children, is a hemangioma, particularly when they have a lesion elsewhere on their body. Often these children will certainly have other signs of cutaneous lesions elsewhere, either on their forehead, the back of their neck, or other parts of their body. And it's always worrisome because it shows up as a mass that's palpable. It has a bluish discoloration, oftentimes in the skin. And as the baby grows over the first few months of life, the hemangioma seems to grow. Now, fortunately, most of these will autoinvolute over the next several years. Sort of the rule of percentages, by 70% of them will disappear in most cases by the time the children are 7 years old. So the idea of being patient is very important. During pregnancy, certainly hemangiomas in the mom may have been a problem, and so mothers may certainly worry more about their baby who happens to have the similar finding, because we do see the lesions run in families on occasion. But again, it's encouraged them to give it time over the next several years to see if it might autoinvolute or outgrow its own blood supply and then disappear. Under the influence of estrogens as the girls go through puberty might be another time when they would see an exacerbation or a growth of a hemangioma that had been very tiny previously but might become larger again. Again, it's being conservative and then just reassessing whether anything surgically needs to be done or not. One of the indications we use if the hemangioma persists is how big is it? Is it causing the girls any difficulties from a pain standpoint? Is it just plain growing larger as the girls are growing? If any of these things occur, then we really ought to consider surgical excision in an attempt to certainly save any breast tissue and to being as conservative with the excision sites as possible. Of the common breast masses that we'll see in the older or the adolescent girl, most common is fibroadenoma, although some fibrocystic disease. We will see some blue dome cysts, and we will see an occasional hemangioma as the girls have gone through puberty that was not previously known or recognized. Keeping in mind that of the 100 or so masses that we will evaluate on a yearly basis at the Children's Hospital, that we very few lesions which are cancerous, that are pre-malignant in any way. The common problems that we see are because of our large oncology population, that we have a lot of our tumors may metastasize to breast tissue, and those will certainly need to be biopsied. So the first thing we would do when we would evaluate an adolescent girl for a breast mass is get a breast ultrasound. It gives us the idea of the characteristics of the mass. It allows us to know whether there's fluid or not, and keeping in mind that the adolescent breast is far too dense for mammography to be helpful at all in detecting either the lesion or the reason why that might be a painful lesion. Rarely do we need to do a final needle aspirate of the mass. If it needs to be excised, we would do an excisional biopsy rather than an FNA. And if there's fluid, we would certainly do it an ultrasound guided or just by palpation, remove the fluid and send it off for cytology just to ensure that it indeed is a benign lesion. So if the lesion is painful, we ask the girls to try to cut down on how much caffeine they're drinking or chocolate that they're eating on a daily basis. Oftentimes that will take care of the discomfort. Pain control should never be a narcotic. It should always be an anti-inflammatory if any is required from that standpoint. Almost always do the girls come in and want the lesion out so that they don't worry about it. When we excise them, we try to make the scars as cosmetic as possible. We try to make periareolar incisions when at all possible and to remove the entire lesion so the pathologist has something to look at. lesions that grow very rapidly certainly shouldn't be observed through one or more menstrual cycles like we do for the smaller fibroadenomas. If they're growing rapidly, they should be excised. If there is fluid from the standpoint of by ultrasound, then we would merely drain this out in the office setting, usually using EMLA on the skin, and again sending the fluid off for cytology. That if there's ever a question about how it feels or whether it's fixed to the skin, certainly a biopsy excising the entire lesion should be the mode of treatment. One of the more problematic areas are when you're dealing with the adolescent boy with gynecomastia. There are really two different types of gynecomastia that we deal with. One is the pseudogynecomastia, or that gynecomastia that occurs in the overweight boy, the boy whose BMI is at least 25, and needs to be put initially on a weight loss program to see if the gynecomastia will resolve. The problem is that gynecomastia, by definition for insurance companies, need to be present for more than 3 years before that they will authorize any surgical intervention if more conservative measures have been unsuccessful. So we can get the children to lose weight for a period of time, but it needs to be a total lifestyle change so that they will continue to keep the weight off. So even if we would proceed to do either liposuction for treatment of the gynecomastia or a simple mastectomy, that the fluid and the fat would not reaccumulate, and so that we would have a persistent cosmetic result for them. The problem is body self-image. The boys will stop playing in sports, which even augments their laziness or their couch potato kinds of lifestyles, so that they won't participate in sports. So that just further complicates the whole issue of how do we get them to lose weight and keep it off if they're unwilling to be out in public on the basketball court wearing a t-shirt because everyone will make fun of them. Insurance companies have a hard time recognizing that psychological issues dealing with the gynecomastia are just as important as any of the physical problems they may have from a standpoint of pain or posture, the developing of scoliosis, because they're trying to hide how the front part of their body looks by bending their bodies and then getting painful scoliosis as a consequence or a secondary issue for them. So when the boys come in with the problem of gynecomastia, oftentimes they will come in either from the primary care physician or they will be referred by the endocrinologist who's already gone through the whole workup for the child to make sure that there's not a hormonal or an exogenous reason for the gynecomastia. We need to make sure that all their medications have been eliminated. Certainly marijuana is one of the more common reasons that we'll see. Even Valium has been associated with the development of gynecomastia if you've been using it on a long-term basis, say for muscle spasms after a sports injury in some children. There's also a family history. There are some families that have an enzymatic deficiency so that they don't metabolize their estrogen as well, and that they have a buildup of estrogen in their bodies and a result in gynecomastia. You also need to do a really good physical examination to make sure that you don't have a tumor somewhere that might be excreting an estrogen hormone. There's also an entity called androgen insensitivity. Whereas the boys go through puberty, the end organ doesn't respond to androgen, and so not only do they might have a short phallus and small testis, but they also start developing breast tissue. Oftentimes these boys are also overweight, so that again you have two different entities at work, and until you can work with their weight loss and deal with the problem of the androgen insensitivity, it's really fruitless to try to do surgical intervention or even talk to the families about the surgical intervention. When the patient comes to us and we have any question about the etiology of the gynecomastia, particularly in bilateral cases, then we'll send them off to the endocrinology group first, make sure that they get cleared from that standpoint, and then we can talk more about the possibility of surgical intervention. With the unilateral gynecomastia that's been persistent for more than 2 years, certainly a simple mastectomy appears to be a good way to permanently alleviate the problem with minimal scarring by making a perioreolar incision. When it comes to the bilateral conditions, then we have two options. One, we can do a simple mastectomy, keep the kids in a brace so that they don't have fluid that reaccumulates underneath these big flaps that you've had to create to excise that extra tissue. And keep them in that brace for several weeks until the skin has a chance to shrink, just like stretch marks, and so that you don't have a recurrence of fluid buildup. The other option is liposuction. If you do an ultrasound and it looks like it's total fat and you do not see discrete breast tissue really, then sending them off to the plastic surgeons to at least talk about liposuction is certainly a good option, and families then can have the opportunities to make the best decision about surgical intervention, types of intervention, and long-term outcomes for the children. When it comes to the adolescent boy with gynecomastia, he certainly wants it gone now. In reality, patience is what you need first. We want to see the kids over a couple of years period of time so that we can make sure that it is either going to resolve, one of that 50% that will resolve, or whether it's something that will need surgical intervention. The problem is that even though you excise say if you do bilateral mastectomies or liposuction, you still need to continue to see the kids back, either by the primary care physician or for surgical follow-up, even if it's just once a year, so that we make sure that, one, we don't have recurrence, and two, that we can make sure that the type of operation that we offer the child gives them the best outcome in the long run. Even though most breast masses that we deal with in the pediatric and adolescent age groups are benign, we need to keep in mind that long-term follow-up is very important. Any child who has had a history of an oncologic issue, who may develop a metastatic lesion, who develops a breast mass, that mass needs to be biopsied or investigated to make sure that it is not a site of metastasis. In most cases, however, it's certainly benign, but long-term follow-up with surgical backup when needed is exceedingly important, just to guarantee that we don't have that small number of patients who might truly have a primary breast cancer in this age group.
Dr. West's presentation reminds us of the full scope of medicine, not only analyzing examination data and prescribing treatment, but also calming concerned parents of infants with breast bumps and being sensitive to the feelings of adolescent girls and boys who are embarrassed by these problems. Riley's team of physicians, nurses, therapists, dietitians, and other health professionals are skilled in providing excellent medical care and in making the hospital experience as comfortable and positive as possible for patients and their families. I'd like to thank Dr. West, along with Drs. Rescorla and Rouse, for their informative presentations in this issue of Riley Today. As we conclude this issue, please take a few moments to log on to the School of Medicine's CME website at cme.medicine.iu.edu/RT. You'll find additional information regarding minimally invasive surgery, neonatal bowel obstruction, and chest lesions in the pediatric population, as well as materials and instructions needed to apply for CME credits. And please send in your comments and suggestions for topics you'd like to see covered in future issues of Riley Today. Your input allows us to present information that will be useful to you and your medical practice. Now, on behalf of Riley Hospital for Children, Clarion Health Partners, and the Indiana University School of Medicine, I'm Barbara Lewis, thanking you for watching Riley Today and inviting you to join us next time.